Hey there and welcome back. Let's just jump right in, shall we? This is the second explainer in our clinician-focused series on visual-induced dizziness, or VID, which is all based on the fantastic literature review from Australian dizziness clinics. Now, in our last explainer, we covered what this actually looks like when a patient walks into your clinic. Today, we're taking a really structured, inside-out approach. We're going to bridge the gap between your patient's super frustrating daily symptoms and the actual physical mechanisms happening deep inside their brain, and then we'll bring it right back out to the bedside to show you exactly how to work this up efficiently.
But real quick, before we get into the weeds, think about this paradox. Why on earth does just 30 seconds of an optokinetic exposure, like staring at a scrolling screen, reproduce 6 whole months of a patient's chronic dizziness? Sounds crazy, right? But the answer is an absolute game changer for your practice. Because when you do this, you're showing the patient, rather than just telling them, exactly what's short-circuiting in their brain. You're completely validating their experience on a physiological level.
So here is our roadmap for today's explainer. We'll unpack visual-vestibular mismatch, define visual dependence, cover 3 bedside provocations, look at the examination screen, and finally, wrap up with the Visual Vertigo Analogue Scale.
All right, first up on the docket, visual-vestibular mismatch and the actual mechanism behind it.
So, normally, how we orient ourselves in space relies on this really beautiful, delicate fusion of 3 distinct sensory streams. We've got our vestibular input from the canals and otoliths, our visual input, especially that peripheral optic flow, and our somatosensory input, like proprioception. Think of your brain as a massive processing hub. It's integrating all 3 of these streams, primarily within a network centered on the parieto-insular vestibular cortex, or PIVC, and the medial superior temporal area. It's basically Grand Central Station for your spatial awareness.
But what happens when things go sideways? Let's say your patient has a vestibular insult, like maybe vestibular neuritis or a concussion. Suddenly, that vestibular signal is completely unreliable. It's sending bad data. So to keep you upright, the brain cleverly reweights those sensory inputs. In most folks, this adaptation totally normalizes within a few weeks. But in a substantial minority of patients, this sensory reweighting becomes maladaptive. The brain essentially gets stuck, becoming persistently over-reliant on the visual stream. The conscious result of this mismatch? When the visual environment is busy but the body's standing still, the brain panics and the patient feels dizzy, literally just from looking around.
Moving right along, let's talk about visual dependence, specifically looking at it as a trait versus a state.
Okay, this right here is the crucial concept, visual dependence. Basically, this is a state, or a trait, where someone's spatial orientation relies way too heavily on visual cues. It is the core underlying mechanism of visually induced dizziness. And here is the absolute best part for you as a clinician. Visual dependence is a modifiable physiological state. It's not permanent. It is the exact target for our rehab, meaning graded optokinetic exposure can actually train the brain to reduce this dependence. So, how do we break this down? Well, trait visual dependence is basically a baseline vulnerability. We can actually spot this in perfectly healthy adults using the rod and disc test, and it literally predicts how severe their dizziness is going to be if they ever suffer a vestibular insult. State visual dependence, on the flip side, is what spikes acutely after an event, like neuritis, a concussion, or a vestibular migraine flare. It's the state that hangs around in conditions like PPPD. And we've got the hard data to back this up. Visually dependent patients show increased bold activity, that's blood oxygen level dependent signal, right there in the MST and PIVC during optokinetic stimulation. The brain is quite literally lighting up in response to the visual overload.
Okay, section 3, bedside provocation. Let's get into 3 specific maneuvers you can use right away.
You don't need a $1 million lab for this. You can actually safely trigger and identify visual dependence right there in your clinic using 3 simple methods. First up, optokinetic stimulation, using full-field stripes or a scrolling screen. Second, a 1 Hz head shake test. You just watch for the difference in their symptom severity when their eyes are open against the patterned background versus when they close them. And third, the Romberg test on foam. Having a patient stand on a squishy foam surface takes away the reliable proprioception. If they suddenly get wobbly with their eyes closed or when facing a busy visual conflict, boom, that strongly supports visual dependence. And guys, this number, 30, is an absolute lifesaver for your daily practice. If you don't have fancy optokinetic equipment, do not sweat it. You've got a smartphone, right? Just have your patient look at your phone, scrolling quickly through a busy, text-heavy web page for just 30 seconds. That is literally less time than it takes to log into most electronic health record systems. And it's a perfectly valid surrogate. It reliably provokes symptoms in VIRD patients and immediately proves the mechanism to them right then and there.
All right, next up is the examination screen, and what I really like to call the power of normality.
Here's the thing. Between dizziness episodes, your standard neuro and vestibular exam for a VID patient is probably going to be completely 100% normal. Smooth pursuit? Normal. Saccades? Normal. Cranial nerves, limb exam? All normal. Even the head impulse test might be normal, or maybe just mildly abnormal if they've had VID for a long time. And you know what? That standard normality is actually incredibly useful diagnostically because it excludes most central causes. Now, obviously, you've still got to actively hunt for central red flags. If you see vertical or direction-changing nystagmus, new gait ataxia, or persistent oscillation, you refer them urgently for imaging, no questions asked. But if the exam is normal, you are firmly, confidently in VID territory.
Let's move on to our final core topic, the Visual Vertigo Analogue Scale, or setting your practical baseline.
So, once you suspect VID, how do you actually measure it? The easiest way to screen is using this 5-feature visual trigger inventory. Just look at the patient and ask, hey, do you get dizzy in supermarket aisles? What about in crowds or when scrolling on screens? Do patterned floors or highway driving mess with your head? If they say yes to 3 or more, that strongly points to VID. And this maps perfectly onto the Visual Vertigo Analogue Scale, or VVAS. It's this super handy, validated 9-item self-report questionnaire put together by Dannenbaum and their team, where patients just rate their dizziness in these specific real-world environments on a scale of 0 to 10.
The whole thing is out of 90 points, and we break it down into 3 super practical bands. Under 15, that's mild. If they're hitting 15 to 40, that's moderate and definitely clinically significant. Anything over 40 indicates a severe disability. As a clinician, you want to grab this VVAS score at baseline, and then just repeat it at 6, 12, and 24 weeks. Watching that score drop is the absolute simplest objective measure of treatment response you could ask for. Plus, it profoundly reassures the patient that their hard work in rehab is actually paying off.
All right, let's wrap this up with some key takeaways and our next steps. Today was all about building that diagnostic bridge. We learned that visual-vestibular mismatch is the foundational mechanism, and visual dependence is what keeps it going. We learned you can trigger it with a 30-second smartphone scroll and measure it with the VVAS. But in our third and final explainer in this series, we are handing you the ultimate management package. We are going to cover the 4-phase visual habituation ladder, exactly when to pull the trigger on SSRIs or SNRIs for a PPPD overlay, how to weave in lifestyle management and CBT, and we'll clearly define those explicit red flag referral triggers so you know exactly when it's time to send a patient to a vestibular physician.
So, as we close out, I want to leave you with a thought. Before you walk into your next clinic, ask yourself, how many normal vestibular exams have you seen just this week that were actually masking a highly treatable visual dependence? Kind of changes how you look at things, doesn't it? To explore more topics on dizziness, vertigo, and imbalance, and to grab the full suite of clinician cheat sheets and patient materials we talked about today, please head over to australiandizzinessclinics.com. And hey, if you found this explainer helpful, please subscribe and leave a rating. We will see you in the next explainer.